Welcome to the Rad-On Smart Review Head and Neck Cancer series.
It is great to be back in the studio.
This is episode 33, Hypopharynx Integration, Decision Points, and Surveillance.
We have a massive amount of ground to cover today. This is arguably the most difficult subsite in the entire head and neck region to manage correctly.
It certainly is. So just to orient everyone, let's quickly recap where we've been in this specific module.
Good idea.
Episode 31. That taught us the biology, the whole worst actor paradigm, the grim reality of the prognosis, and those 4 defaults that really govern our thinking.
Right.
Then, episodes 32 and 32B, that was all about the planning, exactly how to contour, where to extend, the technical side of things.
Right. So we've built the biological foundation and we've established the technical skills.
And now comes the hard part.
Now comes the integration.
Exactly. The mission for today is integration. We're moving beyond, the textbook definitions and the contouring atlases to ask the really hard clinical questions.
Like who actually gets what treatment?
Right. Yes. And what does success actually look like in a disease where survival is historically so low? We need to talk about the complex decision-making, organ preservation versus surgery, how we rigorously assess response, and, what are the realistic expectations for salvage when things go wrong?
And this is where the rubber meets the road. It is about clinical judgment. You can know the contouring atlases by heart, but if you select the wrong patient for organ preservation,
you've done them a disservice.
A huge disservice. Before the first fraction is even delivered, you have to know when to hold them and when to fold them.
So let's just jump right into it. The best way to learn integration is to simulate the clinic. Let's work through this with a case.
Sounds good. Why don't you walk us through the presentation?
Okay, here's our anchor for the session. We have a 62-year-old male. He's a heavy smoker with a 45-pack-year history.
Okay, classic profile.
He presents with progressive dysphagia and hoarseness that's been going on for about 4 months. And he's also lost 15 pounds.
Let's pause there for 1 second. 15 pounds in 4 months. That is not trivial.
Not at all.
In the hypopharynx, significant weight loss is always a massive red flag.
Yeah.
It speaks to the functional obstruction, the tumor physically blocking the food pipe,
Yeah.
but also the catabolic state of the malignancy.
Absolutely. It sets the stage for his nutritional status later and flags him as high risk for treatment interruptions if we aren't super careful.
So what's on exam?
On his physical exam, flexible laryngoscopy shows a mass in the left piriform sinus, and it's extending to the area epiglottic fold.
Okay.
But crucially, the left vocal cord is mobile. He can swallow liquids, but he has difficulty with solids.
Okay, so mobile cords, that is a key data point. It tells us about the depth of invasion into the paraglottic space and, potential cricoretinoid joint involvement.
Right.
If that cord were fixed, we would be having a very different conversation about T-stage and resectability. What does the biopsy say?
Biopsy confirms squamous cell carcinoma.
No surprise there.
For imaging, we have a CT and a PET CT showing a 3.5 centimeter primary with paraglottic involvement. There's a necrotic 3.8 centimeter left level 2 node and a 2.2 centimeter left level 3 node.
Okay, big nodes.
Big nodes. And no distant metastases.
And that necrosis in the node,
yes,
that's classic for HPV-negative disease, which, fits his smoking history perfectly.
Right. And the MRI...
What's that showing us?
The MRI confirms the extent. There's no definite cartilage invasion and no base of tongue involvement.
Okay, good. No cartilage invasion is another critical piece of information.
So staging-wise, we're looking at T3N2BM0, stage 4A.
A very classic presentation. So T3 because...
Wait, you said the cords were mobile.
Mobile cords, right.
Yeah.
T3 because the tumor is larger than 4 centimeters, or actually, check me on this, it's 3.5 centimeters.
Right, so T3 in hypopharynx is defined by tumor larger than 4 centimeters or a fixation of the hemilarynx or R extension to the esophagus.
So with paraglottic involvement, with the paraglottic involvement and extension to the aryepiglottic fold, we often classify these as T3 based on the invasion patterns, but strict size criteria might keep him T2.
Okay.
However, let's assume for the sake of this discussion, the paraglottic extension pushes him into T3 behavior. But really, whether it's T2 or T3, the management bucket is often very similar.
Correct. The clinical note stages him T3N2B based on that imaging extent. And here it is, the consult question from his ENT surgeon. Is this patient a candidate for organ preservation, or should he go straight to surgery?
That is the million-dollar question. And frankly, this is the exact type of case you're going to see on your oral boards.
Oh, absolutely.
The examiners love this because it forces you to synthesize staging, functional anatomy, and trial data. Like instantly. You need a structured, high-level way to answer that immediately.
I agree. So I'm going to give you my 60-second board script. This is how I would frame this locally advanced hypopharynx case if I were sitting in the hot seat.
Go for it.
This is a 62-year-old man with T3 N2B squamous cell carcinoma of the piriform sinus stage 4A disease. He has a functional larynx with mobile cords and preserved swallowing, which makes him a candidate for organ preservation. For T2 to 3 hypopharynx with a functional larynx, guidelines support either definitive concurrent chemoradiation or a response-adapted induction strategy. I favor concurrent chemoradiation with high-dose cisplatin given its established efficacy for larynx preservation, reserving induction for patients who may not tolerate full concurrent therapy, or when response assessment will guide the surgical decision. If we pursue induction, we're looking for complete response to proceed to RT partial response in hypopharynx, historically triggers surgical intervention per the EORTC 24891 paradigm. Planning requires bilateral neck coverage, retropharyngeal nodes, generous inferior extent, and consideration of level 6 given his apex involvement. Response assessment with PET-CT at minimum 12 weeks post-treatment. Late effects include pharyngeal stenosis, and potential PEG dependence rates are higher in hypopharynx than larynx. Prognosis is guarded. 5-year overall survival is approximately 30% for hypopharynx overall, and stage 4 specifically is around 25%. I counsel patients that most will not be long-term survivors, and I involve supportive care early.
That's your framework. That was excellent. Concise, covered the controversy, the anatomy, and the prognosis. Now let's unpack each decision.
The first thing I really want to dig into is this concept of success. Because I think, especially for residents or those newer to head and neck, there's this idea that if the larynx is physically still in the neck, we won.
Right. And that is a dangerous assumption. It's the larynx in a jar fallacy.
Exactly.
Just because the organ is there doesn't mean it's useful. Before we talk about treatment selection and response assessment, we need to define what we are actually trying to achieve.
And that matters because the endpoints in these organ preservation trials can be so misleading if you don't read the fine print.
Completely. So success in hypopharynx cancer is not just larynx still present.
No.
No. Success is disease control plus functional outcome. You have to have both.
So if you have a preserved larynx that doesn't work, meaning the patient can't swallow, can't protect their airway, or requires a permanent tracheostomy and PEG tube, is that a success?
I would argue that is a failure. That is a failed preservation attempt.
It's worse than a failure, really.
In fact, it's the worst of both worlds. The patient kept their larynx, but lost its function, and they didn't get the definitive surgical resection that might have given them better local control.
That is a really powerful way to put it, the worst of both worlds. Because now they have a useless organ that's just a source of aspiration, and they've likely endured high-dose chemoradiation to keep it.
Which means their tissues are fibrotic and vascularly compromised.
Exactly.
It is. When I counsel patients about organ preservation, I frame it very clearly. I say, the goal is to cure your cancer while keeping your ability to speak and swallow. If we can do that, we've succeeded. If we cure your cancer but you can't swallow and need a permanent feeding tube, that's a partial success at best. And if the cancer comes back after radiation, salvage surgery is harder and has more complications than if we'd done surgery first.
That framework disease control plus function, it really needs to guide every single treatment decision we discuss today.
It does.
It's not just about avoiding the scalpel. It is about avoiding the silence and the feeding tube.
Precisely. And speaking of guiding decisions, before we get into the specific treatment selection for our patient, we need to quickly reinforce the planning defaults we learned back in episode 32.
Yes, the defaults.
Yeah.
These are so critical because they don't change based on the treatment approach. Whether you're planning definitive chemoradiation or post-operative radiation, these rules apply.
Okay, let's run through them. Default 1.
Default 1. RPLN is ON. Hypopharynx is not larynx. Retropharyngeal nodes must be covered.
Correct. We see this missed so often. The hypopharynx drainage is distinct from the true vocal cords. The lymphatics drain posteriorly and superiorly. You have to cover the Rouvier's nodes and the lateral retropharyngeal chain. You cannot treat this like a glottic cancer where you might, skip the RPLNS.
And if you miss them?
If you miss the retropharyngeal nodes in a hypopharynx case, you're creating a marginal recurrence that is often unresectable.
It's a fatal flaw in the plan. Okay, default 2.
Default 2. Bilateral neck is on N. Even for lateralized tumors, hypopharynx has bilateral drainage patterns.
Absolutely. The rich lymphatic network here, particularly in the posterior pharyngeal wall and the postcricoid region, means you cannot trust a unilateral field.
No, even if the tumor looks like it's just on one side, the crossover rate is high.
So you treat both sides of the neck.
You treat both sides of the neck, levels 2 through 5, and often level 6. Even for a strictly lateralized piriform sinus tumor, the NCCN guidelines and general consensus strongly favor bilateral treatment because the risk of contralateral failure is simply too high to gamble on.
And default 3.
Default 3. Inferior extent go lower than you want.
This is the one that burns people.
It really is. Submucosal spread in hypopharynx can be 2 to 3 centimeters beyond any visible disease. If you miss inferiorly, salvage is nearly impossible.
That's the key. You have to account for that skipped submucosal spread. You have to chase it down towards the esophagus.
Right. If you stop your field at the bottom of the visible tumor, you are leaving cancer behind. I usually extend my CTV at least 2 to 3 centimeters inferior to the growth tumor volume, and sometimes further if it's tracking down the esophageal inlet. You really have to cover that inferior margin aggressively.
Okay, so keep those defaults in mind, everyone. Now let's tackle the central question for our patient. Is he a candidate for organ preservation?
To answer this, we need to break candidacy down into 4 specific categories. If you systematically evaluate these 4 things, you will never get this decision wrong.
Let's do it. Category 1, tumor factors.
Okay, this is where we stratify the patient based on the extent of disease. We can break this down into, let's say, 3 buckets. First, you have your T1 to T2 N0 disease with small volume.
The University of Florida data suggests keeping it less than 6.5 cc's for piriform sinus tumors, right?
Exactly. For those small early tumors, RT alone is a reasonable option. Or even a partial laryngopharyngectomy if the surgeon is skilled and the anatomy permits. These are actually your best candidates for preservation because the disease burden is low.
Okay, so then you have the middle bucket, T2 to T3 disease, and this is where our patient fits.
Right. For T2 to 3 hypopharynx with a functional larynx, guidelines support either definitive concurrent chemoradiation or a response-adapted induction strategy. This is really the sweet spot for chemoradiation.
The tumor is large enough for aggressive therapy.
But it hasn't yet destroyed the laryngeal framework.
But then there's the third bucket, the T4 disease.
This is a major decision point. T4 means cartilage destruction through the thyroid cartilage or extralaryngeal spread. For these patients, surgery first is generally favored.
Why is that? Why can't we just blast it with chemo and radiation? We do that for T4 tonsil cancers all the time.
The biology is different. Cartilage invasion acts as a sanctuary site. The blood supply is poor, making chemotherapy delivery difficult, and the structural integrity of the larynx is already compromised.
So you're saying when cancer eats through cartilage?
It destroys the scaffolding. Even if you sterilize the cancer with radiation, the cartilage is often necrotic or unstable. You're left with a chondronecrotic larynx that is useless and painful.
And the data supports this.
Oh, yeah. Look at the data point from EORTC 24891.
We are going to talk a lot about that trial in a minute, but what was the specific finding for T4?
In that study, T4 tumors had a 0% complete response rate to induction chemotherapy.
Zero. Wow, 0%. That's statistically condemning.
If the entire premise of that preservation strategy depends on achieving a complete response to proceed to radiation, and T4 tumors never achieve it, then induction-based preservation fails for them. It just doesn't work.
That is a board pearl right there. T4A equals surgery. Okay, let's move to the second category of candidacy, laryngeal function.
This one is simple but critical. The patient must start with a functional larynx to save it.
And define functional for us. What does that mean in this context?
Functional means able to swallow, able to protect the airway, and no aspiration. If the larynx is already non-functional before treatment, if the patient is aspirating, can't swallow, has airway compromise, then preserving it makes no sense.
You're just preserving a structure that doesn't work.
Exactly. Better to remove it and reconstruct. In our case, the patient can swallow liquids and has mobile cords. So his larynx is functional, he clears this hurdle.
Okay, good. Third category, patient factors.
This is where we look at the person, not just the scan. Beatler's 2018 Red Journal editorial crystallized this really well. Patients with a poor prospect of regaining laryngeal function are poor candidates.
What drives that poor prospect?
Lack of support, compliance issues, or just extensive destruction of the laryngeal framework. And of course, persistent smokers.
Smoking status is huge here.
It is. Persistent smokers have worse outcomes with organ preservation and are at a much higher risk for second primaries. Plus, preservation requires intensive support.
It's a marathon.
We are talking 7 weeks of daily treatment, nutritional support, often a temporary feeding tube. If a patient doesn't have reliable transportation or family support, surgery with a shorter course of adjuvant radiation might actually be the safer, more humane choice.
That's a great point. Okay, finally, the fourth category, treatment tolerance.
Can they tolerate cisplatin? We know that organ preservation needs chemo. If they're over 70, have poor renal function, significant hearing loss.
Without concurrent chemotherapy, the outcomes they drop off.
They do. If someone can't take cisplatin, surgery first with adjuvant radiation may be more appropriate. Biologic agents like cetuximab have not shown the same efficacy in the definitive setting for this specific goal compared to high-dose cisplatin.
Okay, so looking at our patient, he's 62, has a functional larynx, T3 disease, and he can likely tolerate cisplatin.
He is a reasonable candidate for organ preservation.
So my recommendation would be definitive concurrent chemoradiation with high-dose cisplatin.
I agree. That is the standard.
Yeah.
If there were concerns about tolerance, you could consider induction TPF followed by response-adapted treatment, but concurrent is cleaner if they can handle it.
Now, you mentioned EORTC 24891 earlier. I want to anchor on that trial because it's the hypopharynx-specific evidence.
It is, and it differs from the larynx trials in a really critical way. We need to be very clear on this.
Walk us through the design.
So, EORTC 24891 enrolled 202 patients. These were T2 to T4 pyriform sinus or aripyglotic fold squamous cell carcinomas.
In the randomization?
They were randomized to surgery with postoperative radiation versus induction cisplatin and 5-FU.
And here is the key mechanism, the really important part.
Right. The induction arm was response adapted. Patients received induction. If and only if they achieved a complete response did they proceed to radiation.
And if they didn't get a complete response, if it was just a partial response.
Surgery. Partial response equals surgery.
And this is distinct from the VA larynx trial.
Very distinct. In VA larynx, partial responders could go on to radiation. In hypopharynx, you need a complete response.
Why the difference? Why is hypopharynx so much stricter?
Because the biology is just more aggressive. In the VA larynx trial, they found that even partial responders could be salvaged with radiation. But in the hypopharynx, leaving any microscopic disease behind after induction proved fatal. You need that robust, complete kill to justify non-surgical management.
What were the outcomes of the trial?
The 5-year overall survival was approximately 30%, and that was equivalent between the two arms. So organ preservation did not compromise survival.
But 30%, I mean, that is a sobering number.
It is, and the 10-year overall survival was only about 13%. Most patients died within 10 years.
That is incredibly tough. And what about the actual preservation rate? How many people kept their larynx?
Of those who survived, approximately 2/3 retained a functional larynx.
Okay.
So if you do the math, 50% overall survival at 5 years times 70% preservation, you are looking at roughly 35% of patients alive with a functional larynx at 5 years.
So roughly 1 in 3 patients actually gets the win alive with a working voice box.
Exactly. The implication for practice is that induction-based preservation only helps if you can declare an early complete response. If the patient doesn't achieve CR, you must pivot quickly to surgery. Don't chase partial responses with more chemotherapy, hoping they'll convert. That just delays definitive treatment and may worsen outcomes.
Okay, let's condense all of this decision-making into a rapid-fire tool. I call this the treatment decision triggers the if-then ladder.
Okay.
I'll give you the clinical scenario. You tell me the move.
Let's climb the ladder.
IFT 1 to T2 and 0, small volume, functional larynx.
Then RT alone or partial laryngopharyngectomy. Either is reasonable.
Okay. IFT 2 to T3, NEN, functional larynx, cisplatin candidate.
Then concurrent chemoradiation is preferred. Alternatively, induction TPF, but only if you strictly mandate complete response to proceed.
IFT 4A, NEN.
Then surgery first. Total laryngopharyngectomy with neck dissection plus adjuvant. Remember the 0% CR rate for T4?
Got it. FFT4B or unresectable, we are talking prevertebral fascia invasion or carotid encasement.
Then concurrent chemoradiation versus palliative care versus clinical trial. You are likely not operating there.
Okay. FT non-functional larynx, regardless of T stage.
Then surgery first. Do not preserve a larynx that doesn't work.
And lastly, IF persistent smoker with poor support or compliance issues.
Then you have to strongly consider surgery first. Organ preservation is a team sport and requires patient engagement.
Perfect. Our patient is T3N2B functional larynx, so we are firmly in the concurrent chemoradiation bucket.
Correct.
So we treat him, we get through the 7 weeks, now what? How do we assess response?
This is where timing is absolutely critical. You start with a clinical assessment exam and nasopharyngolaryngoscopy at about 6 to 8 weeks post-treatment.
And what are you looking for there? Just visible disease?
Visible or palpable disease.
Yeah.
What does the primary site look like? What is happening in the neck? Is the mucosal edema subsiding, or is there an ulceration? Just what's the clinical picture?
And then imaging. Everyone wants to order the PET-CT right away.
And that is a huge mistake. The minimum interval for a post-treatment PET-CT is 12 weeks.
Why do we have to wait that long?
Inflammation. Treatment effect causes FDG uptake that perfectly mimics residual disease. Macrophages, tissue repair, mucositis, all of that lights up on a PET scan.
So if you scan at 8 weeks...
If you scan at 8 weeks and see uptake, you have no idea if that is cancer or just the aftermath of 70 gray.
So you get a false positive, and then what? You biopsy inflamed tissue. You do a surgery you don't need.
Or worse, you perform a neck dissection you didn't need. Don't panic at 8 weeks. Give the treatment time to work.
Now, tell us about the PET neck trial context here. How does that play in?
The PET neck trial was a game changer. It showed that for patients with N2-3 disease who achieve a complete response on PET at 12 weeks, a planned neck dissection can be safely avoided.
And that's a big deal.
80% of patients avoided surgery with equivalent outcomes. It's huge, but that requires a clear, complete response.
Right.
And for hypopharynx specifically, I am even more cautious. I pair that PET response with a rigorous endoscopic exam. I have a very low threshold for biopsy if the primary looks even a little suspicious.
So let's run the surveillance decision tree.
Yep.
Scenario 1. PET is negative at 12 plus weeks, and the clinical exam is clean.
Observation, you're good.
Scenario 2. PET is equivocal. There's some mild uptake, maybe some nodes are still enlarged, but not intensely FDG avid.
This is the tricky one. Do you operate?
I wouldn't think so.
No. Repeat PET-CT in 3 to 6 months is reasonable. But for hypopharynx, I also get a repeat endoscopy and consider biopsy. The key is, do not rush to surgery on equivocal findings.
Okay. Scenario 3. PET is positive and the disease is resectable.
Salvage surgery.
Scenario 4. PET is positive but unresectable.
Then you're looking at re-radiation if it's feasible, systemic therapy, or palliative care.
So the key takeaway here is, don't ignore concerning findings at 12 weeks, but don't jump the gun at 8 weeks.
Exactly. Hypopharynx failures are incredibly hard to salvage, so early detection matters, but accurate detection matters more.
Let's talk about that salvage. Why is it so hard?
When organ preservation fails, salvage typically means a total laryngopharyngectomy. But you aren't just removing the larynx, you're often taking part or all of the pharynx.
Which means you have to rebuild the tube.
Right. You need a reconstruction for swallowing, usually a jejunal free flap or other tissue transfer.
And doing this in a bed of tissue that has received 70 gray of radiation.
It is a recipe for complications. MD Anderson data shows overall complication rates around 38%.
And what's the big fear? The one complication everyone worries about.
Pharyngocutaneous fistula. This is a breakdown of the reconstruction where saliva leaks through the neck. It's devastating. It prolongs hospitalization, delays oral feeding, and can lead to carotid blowout.
And wound healing in general is just poor in that setting.
It is. That is why salvage surgery is so much riskier than upfront surgery. The radiation changes the tissue biology, it creates fibrosis, reduces vascularity. It's just a hostile environment.
We also need to talk about functional toxicity. Even if we cure them, what's the cost?
PEG dependence. In RTOG 9111, at 5 years, severe late dysphagia was 27%.
Almost 1 in 3.
Yes. And remember, hypopharynx is a higher risk site for this than larynx. The risk factors are age over 70, T4 disease, and neck dissection.
So when we tell patients we're saving the voice box, we need to be really honest.
I tell them, even if we cure your cancer and preserve your larynx, there is about a 25 to 30% chance you will have significant swallowing problems years later. Some patients need feeding tubes placed years after treatment.
Years later, not just right after.
Yes. Late dysphagia can present beyond 5 years. Fibrosis is a progressive process. It's a lifelong risk.
This brings us to the prognosis counseling. This This is heavy stuff.
It is the hardest conversation, but we have to have it. Hypopharynx has the worst prognosis of any head-neck subsite, period.
Well, give us the numbers.
5-year overall survival is approximately 30%. 10-year overall survival is approximately 13%.
So most patients do not survive to 10 years.
Correct. And distant mets are a huge problem. About 25% of patients develop distant metastases within the first 2 years. That's the highest rate in head and neck.
So even with perfect local control, we lose people to distant disease.
Yes. So when I counsel patients, I say, the odds of being cured are real. About 1 in 3 patients are alive and well at 5 years. But I have to be honest that most patients with this cancer do not become long-term survivors.
This is why you involve palliative care early.
Absolutely. It is not giving up. It is managing quality of life and goals of care for a high-risk population. It's just good medicine.
Let's loop back to our case and lock in the final plan.
Okay. 62-year-old T3N2B.
Recommendation: definitive concurrent chemoradiation with high-dose cisplatin.
Agreed.
Volumes: bilateral neck levels 2 through 5, bilateral RPLN level 6 because of the apex involvement.
Yeah.
And a generous inferior extent.
Applying all 3 defaults.
Yeah.
RPLN on,
Yeah.
bilateral neck on, go lower than you want.
Dose: 70 gray to gross disease, 63 gray to high-risk subclinical, 56 gray to elective nodes.
Standard dosing? Nothing fancy there.
And for systemic therapy,
Cisplatin 100 milligrams per meter squared every 3 weeks.
or weekly.
Or 40 milligrams per meter squared weekly if tolerance is a concern, but the high dose is the standard of care.
And supportive care.
PEG placement before treatment. With his weight loss and dysphagia, he absolutely needs it. Don't even start without it.
Okay, we are moving into the board review segment. I'm going to quiz you on some common traps.
I am ready.
Trap number 1. You're in the exam room, and you offer concurrent chemoradiation for a T4 hypopharynx case.
And the examiner fails you. The error here is treating T4A like T3. T4 means cartilage destruction. Surgery first is favored. In ERTC 24-891, T4 tumors had a 0% complete response rate. You have to acknowledge the surgical preference.
So what's the board-safe answer?
For T4 hypopharynx with cartilage destruction, I favor surgery first, total laryngopharyngectomy with neck dissection, followed by adjuvant chemoradiation. Upfront chemoradiation has weaker evidence in this setting.
Good. Trap number 2. You accept a partial response to induction chemotherapy and proceed to radiation.
Incorrect. That is the VA larynx paradigm, not hypopharynx. For hypopharynx, EORTC 24-891 requires complete response. Partial response equals surgery.
And the board-safe answer?
Unlike the VA larynx trial, where partial response was acceptable, hypopharynx patients with less than complete response in the EORTC trial went to surgery. If my patient has only partial response, I recommend salvage surgery.
Perfect. Trap number 3. You order a salvage neck dissection based on a PET scan at 8 weeks.
Too early. False positive city.
So what do you say?
BED CT for response assessment should be performed at minimum 12 weeks post-treatment. Earlier imaging has unacceptably high false positive rates due to inflammation. I would observe and repeat at 12 weeks.
Excellent. Now for the board blitz, rapid fire multiple choice.
Hit me.
Question 1. 62-year-old male, T3N2B pyriform sinus, functional larynx, mobile cords. Good performance status. What is the best treatment recommendation? A. Total laryngopharyngectomy and adjuvant RTB. Definitive concurrent chemoradiation with cisplatin. C. Radiation alone to 70 gray. D. Induction chemo, then surgery regardless of response.
The best answer is B. For T2 to 3 with a functional larynx, concurrent chemoradiation is guideline supported. A is for T4A. C omits chemo for N2B disease, which is wrong, and D ignores the response-adapted nature of induction.
Question 2. A patient completes chemoradiation for T3N2B hypopharynx. At 8 weeks post-treatment, neck is palpable normal, primary is healed, PET CT shows moderate uptake in left level 2. Next step, A, immediate neck dissection. B, observation with repeat PET at 12 to 16 weeks. C, reirradiation. D, pembrolizumab.
The answer is B. 8 weeks is too early. It's likely inflammation. Observe and repeat at the proper interval.
Okay, last one. Question 3. 58-year-old female, T4AN1 postcricoid. Cartilage destruction through thyroid cartilage. Larynx is functional. Best recommendation. A, concurrent chemoradiation. B, total laryngopharyngectomy and an adjuvant chemoradiation. C, induction chemo. D, palliative RT.
Answer is B. FICO4A with cartilage destruction favors surgery. Remember the 0% CR rate for T4 in the trials. Don't be fooled by the functional larynx here. The cartilage invasion drives the decision.
We nailed those.
I think the key themes are clear.
Before we wrap up, let's hit the clinical pearls. What are the high-yield takeaways from today?
Pearl 1. EORTC 24891 established that hypopharynx organ preservation is response-adapted. Complete responders proceed to RT, otherwise surgery.
Pearl 2. T4, a hypopharynx, favors surgery first. The evidence for preservation there is weak.
Pearl 3. PET-CT timing matters. Minimum 12 weeks. Don't act on early imaging.
And Pearl 4. Prognosis is poor, 30% 5-year survival. Involve palliative care early.
And don't forget the 3 defaults. RPLNON, bilateral neck-on-N, and inferior extent go lower than you want.
That brings us to the end of episode 33.
We covered the decision framework, the trials, the surveillance, and the reality of prognosis.
I think the take-home message is that hypopharynx is the worst actor subsite. Preservation is possible, but you have to select the right candidates and follow them like a hawk.
And be ready to pivot to surgery if you don't get that complete response.
Next up is episode 33B. That is our mock oral capstone for hypopharynx. We have 4 case blocks that test everything from the defaults to treatment selection.
We are going to pressure test your decision-making with some examiner pushback.
You won't want to miss it.
Complete practice oral boards at radonsmartlearn.com and subscribe to Radon Smart Review for our next episode. Thanks for tuning in.